Hello, this is Ernie Julian. I'm Chief of the Center for Food Protection with the Rhode Island Department of Health, also President of the Association of Food and Drug Officials. And I'd like to welcome you to this webinar about coronavirus. We had over 2,000 who signed up, and the max number of login sites is 1,001. So there's a lot of people who couldn't log in. So if there are people in your building who can join you, feel free to do that. We will put up the webinar as soon as it's over. We'll take steps to do that right away. As soon as it's online, people will receive an email that has been put online. We're very pleased to have Dr. Ian Williams with us today, and we've seen that things have gotten a little crazy over the last few weeks. I was up to about midnight last night writing talking points for our governor in Rhode Island. As of 10 o'clock this morning, all food establishments are no longer allowed to serve food in the facility. They can only be open for takeout and for drive-through and pick up at the site. Same thing has happened in Massachusetts and in other states. So we're seeing things change very quickly to control this pandemic. So again, very pleased to have Dr. Ian Williams, who's the Deputy Incident Manager for CDC's COVID-19 response. He's also branch chief of the Outbreak Response and Prevention Branch in the Division of Foodborne, Waterborne, and Environmental Diseases at the Center for Disease Control and Prevention. Dr. Williams is a graduate of CDC's Epidemic Intelligence Service program. Dr. Williams received his PhD in infectious disease epidemiology from the Johns Hopkins School of Hygiene and Public Health and earned his master's degree in preventive medicine from Ohio State University. He has worked at the CDC since 1994 and has been involved in numerous outbreak investigations. Ian?
Thanks, Ernie. Thanks, Ernie, and good afternoon, everybody. So what I'm going to do today is do some introductory remarks, and then we're going to go quickly through a slide set, and then happy to try to answer questions that I can. And I think along the way, I received some of your questions in advance, so I'll try to answer as many of them as I can through the course of the sort of presentation. As you all are aware, if you're just following the news, that this is a rapidly evolving situation around the world and here in the United States, and it's changing every day and changing very rapidly. We don't have our latest numbers up on the website, but when they go up later today, you'll see that there'll be more than 3,000 cases now reported in the United States. Around 60 deaths have been reported from somewhere around 53 jurisdictions. So things are rapidly changing here in the United States. And you may be aware that towards the end of last week, the World Health Organization characterized the COVID-19 outbreak as a pandemic. And there's been a lot of news around that, what it means. But I think one of the things that we want to tell folks, that really doesn't change much for our approach here in the United States. And it's not really changing our approach to the response. And the reason I say that is this is a new virus, and there are many unknowns. However, the virus that is spreading acts a lot like the flu. And we know a lot from our experience with flu and flu epidemics and flu pandemics. And we know that flu follows a certain pattern. And this is this idea that it comes in a wave which starts slow, then swells, then crests, and then tapers off. And one of the things to say is that different parts of the world are at different points sort of in their pandemic experience. Parts of China look like they've crested and are down the other side. And we're even seeing in different parts of countries, there are different places in the epidemics, different parts of their pandemic experience. And that's sort of what's going on here in the United States. We're sort of seeing where in some places we're starting to see community transmission more in some places around sort of the North Bay of sort of north of San Francisco and the Seattle area and the New York area, some of those sorts of places. But there are other places where spread is still very slow or not really taking off much yet. So we've called this sort of initial phase acceleration. So we're still in the United States in this acceleration phase, and we are accelerating at different places in different ways. But, we had more than 700 cases reported in the last 24 hours or so. So we're still very much in this acceleration phase. Sort of how long this wave lasts, where the peak will be, and how many it affects depends on characteristics of the virus, and we're still learning a lot about the characteristics of the virus. We know it spreads rapidly, much more easily than the flu, but it also depends on our public health response. And again, The overarching goal of our response is really to slow the spread and impact of COVID-19 in every community around the United States. That's really this idea of flattening the wave of illness. And the reason is we don't want to overwhelm our healthcare systems and providers. We don't not just want to blunt, we also want to make that wave even smaller. And we can do that through some of the actions that we're starting to see across the United States. Some of these ideas around social distancing and closures and promoting hand washing, all those good things. One of the things we can say is that the exact actions that are needed will be different for different communities depending on where they are within the disease activity. One of the things I think we're emphasizing is it's very important that the interventions are appropriate to the local circumstances, that actions to lessen spread won't be particularly helpful in a place where there's no spread yet. However, we know getting there early is also an important thing. So our kind of general approach is, be prepared. Cases where there's a few or non-ongoing community spread will have a little bit of time. They need to get ready and start thinking about stuff. Places that have experienced community spread really are leaning into this more. One of the things we also know from our experience sort of here and what we've seen in Europe and China is that the people that are at the highest risk are the most vulnerable, are those people that are older and have severe underlying condition. And really, I just want to talk just for a second about risk and really this idea that when you think about risk in this sort of epidemic here in the United States, there's really sort of two pieces of this. It's the risk of being exposed and getting sick, and then there's the risk of getting very sick, being hospitalized, and potentially dying. And again, as I said earlier, we know that this virus spreads pretty easily in the community. We know from our experience in China and now in Europe that it's highly contagious. And because there's no immunity essentially in the population because it's a brand new virus, we think that it's fair to say that as the trajectory of this outbreak continues and we move towards sort of a peak, that many people in the United States at some point, either this year or next, will become exposed, and there's a good chance that many will become sick. Sort of what those numbers are depend on a number of different things, but we know that those numbers can be smaller if we lean in and do community mitigation. So if you look sort of overall, that basically it was found that around 80% of folks in China, and this was from more than 70,000 people that they looked at, about 80% had mild illness and recovered, and about 15 to 20% developed serious illness. We know, based on the experience out of China, that children do not seem like the people at the highest risk of developing severe disease. So if you look at those 70,000 cases, only about 2% were in people younger than 19. So again, this does seem like a disease that affects adults and most seriously older adults. We know starting around 6 years of age that we start to see this increased risk. And the highest risk seems to be in people older than 80 years of age. We also know that people with serious underlying health conditions are more likely to develop serious outcomes, including death. So the people at greatest risk are going to be older, have serious long-term health conditions like diabetes, heart disease, lung disease. And this really actually helps form the basis of our strategy of focusing on those folks that are at the highest risk for serious illness. We've actually been putting out recommendations focusing on those people at sort of highest risk, making sure that we're thinking about how to protect those folks. We know that in the United States, there are thousands of nursing homes and other long-term care facilities where these folks at the highest risk of serious outcome live and reside. We're sort of seeing experience in this high-risk settings in Washington, where unfortunately we've seen a large number of deaths in some of these long-term care facilities, especially the ones that are skilled nursing facilities. So in the last couple of days, we've been trying to focus guidance and posted guidance for folks in nursing homes and long-term care facilities. Some of these new guidances and policies really mean considering discouraging visitation and screening visitors even before they enter these communities, and really getting people to think about how these people in these communities interact with each other. And the idea is to basically start now before it's even in the community, because those are the places where we think are at the most risk from the serious illness and death. In terms of school guidance, we have posted considerations for decision makers in school guidance. One of the things to say around that is the modeling data that we've looked at, and again, models don't predict the future, but give you an idea of what can and might happen as you vary some of the inputs to these models. But the available modeling data seems to indicate that early to short-term closures of schools probably won't have significant impact on COVID-19. And we know that many schools in the country are closing now and are sort of taking this pause. One of the things to say is that we always encourage businesses, schools, restaurants to consult with your state and local health department, because again, the decisions to be made are sort of best made locally, and we're going to learn as the experience unfolds here in the United States. Some of these communities that are having sustained community spread sort of now, we have teams working with those communities. We're trying to learn what we can and learn what lessons can be translated to other parts of the country. So with that, I thought I would flip really quickly. I have about maybe 10 slides that just answer some basic questions. I'll touch on some of the stuff specifically related to food and food service as we kind of fly through this. So I'm going to now just kind of run through kind of the coronavirus 101, and I think I can do this pretty quickly, and then we'll get to the questions you guys have at the end. Okay, so coronavirus, if you look at the slide that's up on your screen, it's a large family of viruses that cause respiratory illness. It was first isolated back in the 60s. The reason it's called coronavirus is it's named for this sort of crown of spikes on the surface. There's a nice picture there that kind of give you a general idea of sort of what those crown look like. We know it can be spread among animals and people, so it can be zoonotically transmitted. The next slide gives you some of the sort of common human coronaviruses. The ones that you probably have heard about are SARS, severe acute respiratory syndrome, MERS, Middle East respiratory syndrome. So this novel coronavirus falls within these same general families. So we do know some stuff around histories of coronavirus. One of the things we can sort of say about this specifically novel coronavirus is that if you look at the transmissibility, it does look more transmissible than either SARS or MERS, but it is not near as serious in terms of the number of illnesses and deaths as either SARS or MERS. And so overall, it's looking more along the lines of more transmissible than seasonal flu, but also looks like the serious outcome and death look more serious than we would see with a bad seasonal flu year. So that's sort of where it is, and a lot of the modeling is still looking at exactly where that sort of lands, but that's kind of the general feeling for in terms of the transmissibility and the sort of severe outcomes related to it. So if you look what the clinical presentation is, I mean, this just looks like sort of your kind of common cold, mild to moderate upper respiratory tract illness. The bad outcomes, severe disease, it's really pneumonia or bronchitis. The places that we tend to see it is sort of in the very young, the very old, and people with underlying conditions, as I mentioned previously. Symptoms are the pretty generic. What you see is a cold, runny nose, headache, cough, sore throat. There are laboratory tests for COVID-19, and you probably have heard a lot about the availability of those tests. Those tests are very important at the beginning part of the epidemic as we're sort of starting really aggressive community mitigation. This idea that early on in the epidemic in communities, it's important to know about as many cases as you can because you aggressively want to try to contain those people and keep spread from starting in the community. But as spread takes off in the community, testing becomes a little less important, and you move more towards people are going to be, there's going to be lack of availability for people or everyone to get diagnosed, and we're going to have to recommend that people with sort of these presentations either stay home or if they're severely ill, basically seek medical care. So how is COVID-19 spread? It's really spread through respiratory droplets like coughs or sneezes. This is close personal contact, such as touching and shaking hands, touching an object on the surface that has the virus on it. It does look like there's reasonable environmental stability in droplets. The exact sort of upper end of this is still a little bit of debate, but it does actually survive on surfaces, can be on high-touch surfaces, and we'll talk about cleaning and disinfection here in a second, but it's really cleaning and disinfection are an important part of making sure to prevent the spread of this, especially those that are high-touch surfaces. So these coronaviruses occur year-round. Young children are most likely to get infected in general. Again, this COVID-19 is a little unique, as we're not seeing severe illness in children, which is a little different from some of these other ones. And if you look in general at the human coronavirus, most people get infected at least once in their lifetime with these things. So just a little stuff that you probably know from the media. This was identified in central China back in the end of last year. There were a lot of cases linked to this large seafood and animal market early on. Later on, we started to see essentially person-to-person transmission, and then basically it started to spread. The first travel-related exportation of cases basically happened back in the middle part of January. So as you all probably know, COVID-19 cases are reportable. There's a system set up. There's a link on here to tell you how to both diagnose, test, and report cases to CDC. And there's a whole epi group downstairs working very hard with our state and local folks to make sure that cases that are identified are reported to CDC. But this is critical sort of early on in the epidemic, where we still are, to try to understand the epidemiologic characteristics of folks that are getting infected, sort of how it's spreading, and also to help communities try to understand where they are in this sort of their mitigation strategies, when they need to turn the dial from sort of a lower mitigation strategy to a more aggressive mitigation strategy. Okay, so how it spreads, and this is something that I've gotten a lot of questions on, and a lot of questions from the food service and food world. So one of the things to say is, again, this is a brand new virus that investigations are ongoing to better understand exactly what's going on. Largely what we know is based on stuff from other coronaviruses. Based on what we know from other coronaviruses, that the predominant mode of transmission is really through close person-to-person contact. This is sort of the respiratory droplet that occur when people are basically cough or sneeze. There's also this idea that it's possibly by touching surfaces where those respiratory droplets sort of land that has the virus on it. And then touching, and it says on here, mouth, nose, or eyes. You know, if you look at the relative contribution of the eyes, the nose to the mouth, there is no evidence out there that so far with this that we are not seeing foodborne driven or food service driven spread of this. This really is respiratory person to person. And I talked to one of our sort of local scientific experts sort of on coronavirus earlier today, and talked a little bit about sort of the relatively contribution of sort of respiratory versus oral sort of spread. And the way he kind of explained it is that a lot of this has to do with sort of how this virus actually gets into you, and there's really this thing called an ACE2 receptor and where you find those things. So these receptors are mostly on in your respiratory tract, so in your sort of nose, in your trachea, in your bronchioles, sort of in your lungs. There are not actually that many of them sort of in the esophagus and down into your stomach, even though you can find them there. So it's really this idea of sort of like what does transmit sort of COVID-19 and what could transmit. So clearly this sort of respiratory spread is sort of how it is spreading. There is a sort of, I guess, a theoretic likelihood that you could spread it through sort of oral ingestion of this. There is really no data that says this is happening now. It's probably pretty hard to figure out given how overwhelming the respiratory spread is. But I can tell you that right now there is no sort of definitive data saying that either fecal or oral spread is a predominant way that this is spreading currently around the world and in the United States. Okay, so just a little bit, almost done with slides, and then I'll do some questions, is that here's symptoms and complications. Incubation period is 2 to 14 days. Most people get sort of actually ill in that sort of 3 to 6 day window, a lot around sort of day 4, day 5, day 6. Again, there's a wide range of severities. The complications are those things you think with severe respiratory disease, pneumonia, respiratory failure, and again, focused on the very young and the very old. So prevention and treatment. Prevention is the basic stuff we tell everybody: wash your hands with soap and water, use an alcohol-based hand sanitizer if you don't have soap and water, avoid touching your eyes and nose and mouth with unwashed hands, avoid close contact with people who are sick, stay home if you're sick, cough and cover your sneeze, clean and disinfect objects and surfaces. So this is, I think, the last slide, or next to the last slide there, showing this idea that we want everybody in the community to know that they can sort of play their part in helping prevent the spread of this. Again, avoiding close contact with people who are sick, wash your hands, stay away. If you're sick, stay home, don't spread this. Don't go stay away from people that are the most vulnerable if you're sick, the elderly, people's underlying conditions. There's lots and lots of stuff up on our website, lots of good information around guidances around what to do for businesses. There's a whole guidance on how to clean and sanitize. I can point you guys towards a lot of it around businesses and what businesses can do. And I think just to summarize sort of a lot of that sort of material, a lot of the business stuff, and would apply to food service as well, is sort of think about sort of what you're going to do before this shows up in your community. What are you going to do if you have a sick worker? Encourage workers who are sick not to come into work as well. What are you going to do if you have a sick patron? There are no kind of hard and fast answers to a lot of these things because the risk really varies depending on the type and situation. And what we've basically been telling people is these need to be evaluated on really a case-by-case basis to try to stratify into sort of, is this a low, a medium, a high-risk exposure? And those are all driven by type of contact, what they were doing. And we're also encouraging everybody to engage your local and state health department. They're the best people who can come work with you, work with businesses to try to evaluate this risk, try to make what's the most sensible recommendation. And again, this all needs to be taken in the context of what's going on in the community as well. Are you at the very early stage and have very few or no cases in your community? Are you a community where there's already widespread? Because what you're going to do may vary depending on where you're there. And CDC guidance, I would say, is trying to be sort of high level and not being too overly prescriptive, and allowing enough flexibility for our state and local health colleagues to figure out sort of what's the right fit to them, but still providing some high level guidance for them. So let me just look quickly at to make sure I covered a lot of the questions that you guys asked. I'm flipping my pieces of paper. Here we go. And then we'll open it up to questions for you. So a lot of the questions, again, are, do we need more specific guidance for essentially food handling? And at this point, I think CDC's intent is CDC is not going to put out, or at least have not heard they're putting out specific guidance for food and food handling. And I think some of this is because at this point, there is no evidence really pointing us towards food service are ways that are actually driving the epidemic. And we had a talk actually yesterday between FDA and CDC, FDA, and USDA. And I think that our colleagues at FDA and USDA may put out some general guidance sort of around stuff. But the stuff that's going to be in the guidance is the things that you guys should be doing every day. You know, step one, keep human fecal material out of our food. Do the hand washing that we're always doing. Do cleaning the way you guys always do. I think some of the considerations are, again, towards high touch kind of surfaces. Really think about, are you cleaning them on an accelerated schedule? The cleaning and disinfection you're going to do is pretty much what you're doing already. That we know that the disinfectants that are out there appear to be effective to this. It's our kind of standard things that we would use, diluted household bleach solutions. We have guidance for how you clean linens and laundry. And the idea is that, really pretty much anything with an EPA-approved emerging viral pathogens claim would be appropriate to what you essentially need to do for sort of cleaning or for disinfection kind of things. So maybe I will stop there and turn it back to Ernie, and then say I'm happy to try to answer sort of questions since I've been talking for a while. So back to you, Ernie.
Thanks, Ian. I think that's very helpful. One of the other questions that came up a lot, and I know that you're giving a lot of flexibility to states, but I've seen in the questions that were submitted, you've got a roommate or a family member who's under quarantine. They weren't ill, but they were exposed. Does the food worker need to be restricted in any way when that kind of situation occurs?
So based on what we know, sort of the answer is the no. However, if they're sick, they need to stay home and they need to be monitoring themselves for illness. If that person under quarantine gets sick, that changes the whole situation, and then you have to evaluate what was that person's contact, then maybe they need to be essentially stay at home around those things. But the bottom line, at least now in the community, is that people who are well, we're not recommending that they go out and get tested, and for a couple of reasons. There's still relatively limited testing here in the United States is one reason, and a negative test doesn't necessarily mean that you're negative, because you could be in the incubation period. You're at day 3, and you're not going to actually get ill till day 10. So a negative test doesn't mean you're negative. So we're not recommending they stay home. One of the other things I should say that will be coming out later today that we've actually got a lot of questions about is, what should I do with people who have been diagnosed with COVID-19? Should they stay home? What should they do, especially in an era if they can't actually get testing? So there'll be some guidance today that will help with that. And at sort of a high level, the way that guidance sort of is reading is that you need to stay home at least 72 hours after essentially your fever stops and without being on Tylenol or another fever reducer. So 3 days after that stops, and your symptoms have abated, more or less abated, and the total period from the start you got sick till that sort of time, 3 days better, has to be at least 7 days. So the idea is 7 days in total, at least 72 hours after you get better is kind of the guidance we're moving towards, especially if folks are having trouble getting testing at the end. Long answer to a simple question. I know.
That's great new information. Thank you. And I'm looking at other kind of questions that have come up here. So I think you've answered a number of them. There's not a lot of, since there's no evidence of foodborne transmission at this point in time. If you've got questions in the audience here, and we can open up the lines too, but you can type them in the question area. And in the meantime, I'm just looking through other questions to see, and Ian answered most of them. So if you've got a worker, let's say it's a waitress who turns out positive and was a sit-down restaurant, any advice there about what the action should be?
Yeah, I think this is like we would say, call your state or local health department, evaluate what the risk is and what they did. And we've actually have some general guidance about helping state or local health departments kind of walk through sort of what that risk sort of is. And we've had to kind of come up with some general guidance, which is our best guess based on, a number of situations that have come up about situations exactly like that. You sat next to somebody at dinner, am I at high risk? And so I think they have some general guidance to help you kind of quantify whether you're at sort of a high, medium, or low risk based on that. I think a lot of it has to do with how ill the person was and sort of what the kind of proximity was to the person during it. But again, because this is predominantly droplet spread, it's really that kind of close personal contact, being within 6 feet of somebody, having kind of sustained kind of exposure to a person who is actually ill. Maybe one other thing to say is there's been a lot of discussion in the last day or 2 or 3 about the role of asymptomatic people in the spread here. There's still a fair amount of debate about sort of what the role asymptomatic people actually kind of play and how many are asymptomatic. And I don't think we have all the answers here right now, as we know that basically people who are symptomatic or maybe just pre-symptomatic, like right before they become ill, can and do transmit. This role of like the pre-symptomatic window, it's not exactly clear, and there's sort of conflicting studies out there. But we think that most of the transmission is driven by essentially ill people. So, if you sat next to somebody who was essentially well, they became sick 2 days later, that still looks like overall that's really a kind of a lower risk exposure based on the data we know today. Over.
I'm looking at the how long does the virus stay on surfaces is one question that just came in.
Yeah, so there's sort of an evolving bit of literature, about sort of how long this does. And I've sort of seen estimates kind of all over the place a little bit. So it depends a little bit on the substrate that it lands on, but it does survive at least a couple of hours and maybe longer, and it may be days, and some people have reported, longer than that on the right substrate. So I think this leads us back to some of these ideas of cleaning of high-touch surfaces, where it seems to make sense to like keep after and have a regular sort of cleaning kind of regimen for those sort of high-touch areas, but also going back to that recommendation of making sure people are washing their hands appropriately. So hopefully this idea of having kind of aggressive hand washing in the community, cleaning of high touch surfaces will help minimize that risk, because it does look like there's a reasonable amount of sort of environmental stability, but again, it just depends from surface to surface. Over.
And then another question that came in is, how likely is it that we'll see a second round of the virus this year? And we're not through the first round, but anyway, what's the likelihood it will pop up again?
Yeah, I think that it's very hard to predict the future and know what's going to happen. I mean, we know from our flu experience that sometimes that happens. Things slow down in the summer months and then it comes back in the fall. We know from previous flu pandemic experiences that it can move from hemisphere to hemisphere and come back. I think people don't know exactly what's going to happen. And a couple of things to say is I mean, people are very anxiously watching what's going on sort of in China now, where it looks like they've kind of gone past the peak and maybe going down the other side. What's their experience going to be? One of the things to say too is that a number of the things they did in China in order to sort of blunt the transmission, the community mitigation they did, are things that are not going to necessarily be applicable here in the United States due to the form of government they have there. So it's sort of hard to be able to know exactly what they did in China, how that translates to here. So we are sort of expecting that this will go on for a while. We don't know when we're going to hit the peak. We don't know how high the peak's going to be. But I think the message that we're sort of saying is that we know we can do things to slow this down. And really, there's a couple of reasons also to do this community mitigation. One is, the hope of a vaccine. There can be a vaccine for this, and it's sort of underway, but we're still a yearish out before really having a vaccine. So if it does look like this turns into something that's going to go and come back and continue for a period of time, I mean, there is hope that we can come up with an effective vaccine for it. The other thing to say too is that there are a number of antiviral drugs, or at least a couple sort of in clinical trial right now. And we know from our experience in flu that we can give antiviral medications to people who are seriously ill sort of early on in the course and actually have better clinical outcomes. So I think, again, the hope is we'll get some experience with some of those antiviral medications, understand where they work, how they work. So again, the further we can sort of blunt and push things down, it gives us more hope of actually coming up with effective therapies, and also really not overwhelming our healthcare system, running out of hospital beds and things like that if we can continue to blunt kind of that peak. Over.
Right, and a number of states, including mine, have put out recommendations about not eating in fact, they've actually banned dining in restaurants. And one of the questions here is basically, should people eat and prepare food at home and not go out to eat? And again, I'm sure it's going to depend on the level of illness in the community, but I know CDC put out an advisory about not having groups 50 or more. Do you have a feeling about restaurants where you may have 100 people in the place?
Yeah, I think a lot of this is to try to, it's really this idea around mass gatherings where people are kind of packed together closely, and it sort of varies from place to place. And this is, again, trying to give state and locals sort of the flexibility to interpret it in a way that sort of makes the most sense to them. Really, the idea behind doing this is to, that kind of close personal contact. We don't want, 10 people or, 200 people to pack into a bar shoulder to shoulder to see a concert, those sort of things. That seems like not a great way that seems like a way to potentially promote spread. And so that's why I think a number of places are sort of taking this approach to try to sort of limit the people getting together sort of in confined spaces. And again, doing it early is not necessarily a bad thing, because if it's already sort of spreading in the community, you're almost a little bit, if it's sort of spreading a lot in the community, doing those things may not slow it down as much as if you start earlier. So it's really, again, in different places are interpreting it differently. And I think that is okay now. We're kind of allowing folks to figure out what makes sense to them, what makes sense in their community. But one thing I would say, too, is that, the issue is turning these things on are easier than figuring out when to turn them off. And, our experience, if you look, or the experience in China is the peak didn't happen for a number of weeks. So potentially, we're going to be in this sort of acceleration phase here in the United States for a number of weeks. I don't know how long it's going to be, but, we've sort of seen a rapid rise here gone, very quickly from, less than 50 cases to, more than 3,000 here in a pretty short sort of time. So again, we don't know where that peak's going to be, but it's likely not going to be in the next week or two. It may be, several weeks, month or two. That's what we're kind of waiting to see. Over.
Okay. One of the things that has also come up, and maybe this is just information for the group, is yesterday I was able to get a hold of Grubhub, and a lot of people are going to home delivery for a whole bunch of different foods. And one of the things we're seeing here, and I'm hearing the same thing from other states, is we're telling people to have social distancing, and yet the supermarkets are jammed, and there's no food on the shelves. Basically people are hoarding and wiping out the places. So with Grubhub yesterday, they had already put out something to all of their drivers and to their food establishments talking about not having people work while they're ill and delivering food while they're ill, and avoiding, direct contact when they're delivering products. So we're having some additional discussions with Uber Eats, and then DoorDash is another one. So the home delivery groups, to make sure that we don't have people delivering food who are ill. So any comments about stores? I mean, how about salad bars in stores as a potential source of illness transmission? People coughing on them going by, with the sneeze guards and those kind of things.
Yeah, and I can sort of say that there is no data on that stuff right now. Some of this is the common sense sort of things. Again, it's going back a little bit to the high touch surfaces. It's, getting stuff on your hands, and if you're in a store and you rub your eyes or your nose, you may actually transmit it to yourself. So I think some people there's a little bit of this what makes common sense kind of things. And I can tell you, unfortunately, there is no data one way or the other that says this. Based on the data we do know, it's probably not consuming the salad is a major driver of this, but however, handling the utensils and the things potentially could be. So that's why there's sort of this mix of like what's the right thing to do. And again, I think people are going to take different approaches to that. But going back to your earlier kind of comment, I think the idea of really making sure people who are ill don't work is an important piece of this. And another important piece of this is going back to like who is at the highest risk for this. Going back to people who are older, have underlying immune conditions, really need to think about, carefully about what they're doing when they go out in the community, what they're doing in terms of social distancing. So if they need to shop, when are they doing it? They may want to think about doing it at a different time, late at night or early in the day. Those sort of things in order to promote social distancing, because even though I think the risk of having a severe outcome is different based on who you are. We don't want people to get sick, but we really want to try to protect that kind of vulnerable population as much as we can. Long answer to a simple question, I know.
Oh, that's fine. Another question that came up was the whole issue of reusable bags. A lot of states have pushed that for resource conservation, and yet you've got product bags coming into a food establishment, a store, or wherever that potentially could be contaminated from home. Any feeling on that?
Yeah, I don't think we have any data to sort of say one way or the other. We do have guidelines. If you want to clean and sanitize, we can tell you how to clean your bag there. Yeah, again, it's probably like not a major driver of sort of what's making people sick. We also get questions about, handling of money and handling of credit cards, those sort of things, and whether it makes sense for people to like stop taking cash money and just move to credit cards. And I think there is no sort of specific data that sort of tells you what is the right answer here. I think it's, the idea is that what makes sense and what is practicable and what are the downstream consequences of making a decision. If you do this, does it actually cause you to have more high touch there? And at the end of the day, when we've talked to a lot of folks, especially for workers, is workers who are in sort of high touch things, they're receiving money or credit cards, try to make sure they have access to appropriate hand washing, hand sanitizer. We did actually put some guidance out about touch screens. Most of this was around some of the election stuff that's going on, to try to give some guidance about sort of cleaning and how to clean touch screens between people. So there's some of that guidance up there that may be applicable to folks who are kind of out there working and maybe sort of encountering situations where they're having to have kind of more personal or closer interaction with people. Over.
We've got another question here about when to close a food establishment. So let's say you've got a worker who was coughing all over the place. Would you have any recommendations on when closure should occur?
Yeah, I think a lot of closure stuff. It again depends on the nature of what that person was exactly doing. You know, a lot of this is going to be, and really this applies mostly to the healthcare setting. Is, you know, if there are a lot of people out ill, then you can't actually run your business. And it looks like, you know, people who are out will be out for a minimum of a week at least, and longer if their illness, you know, proceeds. Because the guidance I just told you is they have to be out at least a week, and then 72 hours after they're essentially afebrile. So there could be an issue where you're going to have a number of people out of work for a period of time, and the business may not actually have enough people to think about sort of being sustainable with this. So that's, I think, a consideration. But, you know, in terms of actually an exposure from a food service worker, contaminating through cough and those sort of things, I don't really envision sort of that's the reason to close it. There may need to be situations where, like we've seen in schools, where it may make sense, depending on what the worker is doing, to essentially close, to basically do a period of disinfection and cleaning before you reopen. That's being done in a couple of been done in a couple of schools around here. That can be makes sense depending on where you are again and the kind of community spread here, especially early on. It can make sense to think about doing that, but we'd always say those decisions are made best in consultation with your state and local health departments, because they can help customize and figure out like what exactly makes sense based on kind of the individual situation. Over.
Okay. Amy, why don't we take some calls? We've got a lot of written comments here, but instead of my just reading them all, and some of them get redundant, but why don't we take some calls coming in?
So you would like people to raise their hands and let them talk?
Yeah. Let's do that for a while. We've got a lot of time left, and then we can fill in some of the written comments later, and that gives me some time to look through them, because a lot of them are redundant. So give some people some time to talk.
Okay, go ahead and raise your hand if you have a question. We will try to get to you. Just a note, if your audio is not working, then we will just move on to the next person.
Okay. And in the meantime, you know, if we've got hands coming up, and Amy, if you can watch for the hands, you know, what I'll do in the meantime is I'll kind of scroll down through here through the questions to see what else we haven't covered yet, because a number of these things Ian has already talked about, and kind of cull through those. Let's see. So we've got some basics. So basically what you're saying right now is normal cleaning and sanitization would be effective. There's a question here about what part per million to use for chlorine. So from what the data you've seen so far, normal cleaning and disinfection.
Yeah, so there's actually really good guidance up on our website. So if you just go to the CDC COVID-19 thing, it's called Environmental Cleaning and Disinfection Recommendations. So the way these are sort of set up, I'll just kind of give you the high level kind of piece. Is that it really has you sort of think about, like, what kind of facility are you? You know, are you a school, a daycare? You know, are people there 24 hours a day or not? Do you have people, you know, sort of staying there overnight? And that sort of helps guide you a little bit as to sort of how you think about doing this. But it's sort of the stuff that you guys know very well about how to clean and disinfect. If the surfaces are dirty, they should be cleaned using a detergent with soap or water prior to disinfection. For disinfection, diluted household bleach and alcohol solutions with at least 70% alcohol. And the most common EPA-registered household disinfectant should be infected. If you're going to use diluted household bleach, you need to make sure it's appropriate for the surface. You follow manufacturer's instructions. You know, it's basically a third of a cup of bleach in a gallon of water, 4 teaspoons per quart, you know, that kind of stuff. There's also guidance on linens, clothing, and other things that you need to launder. So if you want to launder those reusable bags, it gives you a way to basically do this. It gives some guidance on sort of what workers need to wear while they're doing the cleaning and disinfection, you know, sort of how to use sort of its glove use. And then that's kind of the high level stuff. So it's pretty much the things you guys should know and how to do pretty much every day and do day in and day out. Does that answer the question, Ernie?
Yeah, I think it does. And I see a question here: is it recommended for independent living facilities to stop communal dining?
Yeah, so this is really on sort of a case-by-case basis, and it depends on sort of the setting and who the setting is. I know a number of long-term care facilities, especially those that are skilled care, are moving towards that. And I think CDC has been sort of encouraging people, settings where you have the most vulnerable, to consider doing that. Again, it really needs, I think, to be customized from place to place. We know it's not practicable to basically stop all communal dining in a place like a prison, for example. It can be very difficult to figure out how to do that. So that's why I think that we've provided some general guidance and then allowed folks to try to figure out what works best in their given situation. Over.
I see another question, and I think you've kind of addressed this. So, is there any testing information about a kill temperature, high or low, for this particular virus? It talks about over 165. Is there any evidence about it dying below 40 degrees? You may not have it.
So I can tell you the upper end. There's no specific data saying it's any more heat stable or heat resistant than anything else. So I think, your standard cooking temperatures that you guys know all very well should do it. I think on the bottom end, I believe you can stabilize this by freezing it. So I think that's how they can ship swabs frozen, I believe. So I think that the freezing part is probably not an effective sort of kill step, but I don't know that for 100% sure, but I believe it's not. But there's no reason to think that, typical temperatures you use in food service shouldn't actually be completely effective to basically kill COVID-19.
Okay. And I'm kind of scrolling through the questions here, and some you've answered already. Amy, do we have any hands up?
I do have one question from Crystal. Is there any guidance for inspectors going into facilities?
Guidance for inspectors going to facilities. I don't think we have specific guidance other than sort of the common sense sort of stuff. Think about, like any sort of workplace, are you practicing appropriate social distancing? If you're sick, you shouldn't go in. Hopefully the places where you're going don't have sick people there too. But I would just sort of think about the appropriate social distancing, hand washing, those sort of things that you would do sort of anyway to prevent, transmission of any sort of cold or flu virus. But, nothing special in terms of guidance other than what you would ordinarily be doing. Over.
Okay, Ernie, would you like to turn to the phones? I have a couple hands raised.
Yeah, let's break it up that way. Go ahead.
Okay, I am going to unmute Caroline Boltman. Caroline, if you would like to ask your question, I will unmute you.
Hello, yes. So I am a nurse working in an ambulatory surgery center, and I'm the infection control person in charge of all this wonderful stuff. What we're wondering is there any benefit to taking temperatures of everyone coming into the building daily, or is simply having them fill out questionnaires about travel, being around people, having been sick recently, any respiratory issues, is that enough?
So again, I'm going to sort of say it's a sort of a local decision, and it depends sort of where you are in the overall kind of experience in your community.
Starting to pop up more. We've had 3 new cases in the last 24 hours pop up.
Right, and so I think some of this is again, it's going to depend on sort of, you're an ambulatory care facility. Do you have sort of high risk folks sort of in your facility? You may want to be a little more aggressive than sort of other places. So again, it's sort of on a case by case basis. We don't want sick people coming to work. We don't want them spreading. We want to try to protect the people that are most vulnerable. So being, again, sort of when you turn that dial up to doing sort of more aggressive things like temperature and temperature monitoring among your employees, it sort of, again, depends a little bit on a place by place kind of thing. And that's why CDC is not going to second guess what you do, I think, because you're there. And we would, again, encourage you to talk to your state and local health department because they're the ones who can probably guide you best on those things. Does that make sense?
Okay. Yep. Thank you.
Okay. Amy,
okay,
did you have
I am going to... Oh, go ahead.
No, go ahead.
I am going to unmute Jesse Neese. Jesse, you will be able to answer your question. Okay, it looks like that is not working. Let's move on to Michael Kalish. Michael, you will be able to ask your question. I will unmute you.
Can you hear me okay?
Yes.
Great, thank you. Can you hear me okay?
Yes.
Okay, great. You mentioned that the virus can survive on surfaces for hours, days, maybe a month, depending on the substrate. Are there any substrate qualities or categories that food manufacturers ought to be aware of? So like in terms of categories might be like stainless steel, plastic, or a specific food type. For qualities, it might be water activity, pH, things like that.
Yeah, I think there's not enough data to know, and I want to start. I didn't want to say months, but the idea is days and potentially longer than that. There's a little bit of this again about sort of viral viability. You know, a lot of these things are done with PCR polymerase chain reaction testing, and just because you can find a PCR positive doesn't necessarily mean that the virus is actually viable. So some of these things are hard to do. They're still in the process of doing some of these. It's really sort of two pieces. I don't think there's clear guidance on which exact substrates are better versus others, but it does, from what I've seen, there is some variability depending on the substrate. It also depends a little bit on the viral load as well, how much virus is there, those sorts of things. So it's hard to come up with an exact answer, and I think at this point there's no guidance specifically about this versus that. But again, sort of doing kind of cleaning and that leads us towards more of the cleaning and disinfection. If you have a surface, you have to think about cleaning and disinfecting it, especially if it's a high-touch surface. Over.
Okay. Amy, another call?
Yes, we have Tracy Nugent. Tracy, I am going to unmute you and you can ask your question.
I'm sorry, I'm good. Thank you.
Okay. We will move on to Tyler Bickford. Tyler, I am going to unmute you and you can ask your question.
Hey, can you hear me?
Yes, you can.
All right, perfect. So I was wondering if, from a restaurant setting, if we should be treating COVID-19 as a reportable illness, like similar to what we would do for E. coli or salmonella.
So we're asking, at least at this point, our state and local health department colleagues to basically track all illnesses in the community and, report those to CDC. We realize that there are some places in the United States that are getting a little further behind in their reporting. So we're hoping that diagnosed cases in communities are being identified and reported at sort of this phase of the this sort of phase where we are in the United States. And the reason it's important, and we kind of keep encouraging state and locals to report to us, it's important to understand, I think nationally, like who's getting sick, what the outcomes are. Because again, the experience that we've seen in China and seeing Europe may not be the same here in the United States. So I think it's important for us to understand, especially in the first several thousand cases that we see, sort of who are they, how it's spreading. And also to say too, that it also helps communities sort of learn what's going on. We're in the process of standing up a lot of the illness surveillance systems that are used for our seasonal influenza. We're turning on the switch for many of those, which focus on influenza-like illness. So those are being spun up across the United States to give us a little more data on what's happening in various communities. At least 5 or 6 communities have already turned this on. Sort of larger nationwide stuff is in the process being turned on. We're starting to get data actually from the private labs as they spool up about what their testing looks like, both the positives and negatives. So, at the end of the day, we do want cases reported to us at this phase, especially. So a long answer to a simple question, but yes, we want state and local health departments to report. And if you have cases, hopefully your healthcare providers who diagnosed you are working with your state or local health department to make sure that report happens. Over.
Thank you.
All right. I've got a question here that, came in by email. Any guidance for restaurants that have temporarily closed and may reopen after the COVID outbreak ends? Should restaurants only reopen until authorization is granted by the local or state regulatory authority? Is there any guidance prior to opening? What other protocols should be followed?
Yeah, so at this point, we don't know when to recommend folks open. and again, as I mentioned earlier, this is kind of the harder question to know that. It's sometimes easier to know when to close. It's harder to know exactly when to open. I'm going to give sort of the same answer I said before. A lot of this is going to be in consultation with state and local health department sort of colleagues. If there's a reason to do cleaning and disinfection sort of in the site, that may make sense. Some schools are actually doing that, where if they have a diagnosed case, they'll close for a day or two, they'll clean and disinfect, and then they'll open. Some other school districts are taking we're going to close for a while without being clear when they're going to reopen. But I would say state or local guidance would be the right way to look for that, because again, it's going to vary from location to location and place to place, and it might be different if you are serving predominantly high-risk people. Might be different if you're in a daycare. It might be different from place to place. So that's why I think local guidance will help you. Over.
Okay. Amy, you want to take another hand?
Yes. James Webb, I am going to unmute you, and you may ask your question.
Thank you. You guys have environmental swabbing. Are you guys going to have any particular protocol to ensure for consistent sampling and results and reporting? 1, and 2, are there surveillance systems set up for individuals like Alaska and those individuals on Native American reservations that could perhaps be, I guess, comparative or comparison type subgroups to see if the virus is affecting them as well?
So the first one first is that there are some protocols about how to do sort of swabbing, and one of the things to say, it's not clear what the role of sort of environmental testing actually is. I mean, at this point, it's meant more to sort of inform. It's more sort of in a research kind of thing to understand. There's been some stuff done on cruise ships, especially when they have those outbreaks, to try to understand what could actually be driving kind of outbreaks and infections. But at this point, there's no sort of guidance to do environmental swabbing in order to determine if a surface is clean or not, at least in a routine sort of way. And I'm not anticipating that sort of guidance will come sort of forward. In terms of your other question, is so yeah, actually we have spent a fair amount of time actually consulting with sort of our colleagues that are the federal tribal societies, and actually they are reporting disease, reporting illnesses sort of as well. We've worked out reporting mechanisms with them. So there's no reason to think that their experience will be any different than other parts of the country. However, we are sort of in close contact with them. And again, the communities vary across the country, and the steps they may take in tribal communities may look different than will take in other communities. And I think that that's appropriate because they know their communities best and can make decisions that make sense to them. Over. So, hey, Ernie, can I do one more question? Because I have to actually be someplace at 4 o'clock.
Okay, sure. Why don't we take another one online here? Or take another call.
Okay. Vicki Snyder, I am going to unmute you, and you can ask your question.
Can you hear me okay?
Yes, we can.
So my question is, are people able to get the COVID-19 more than once?
Yeah, good question. So based on what we know now, no. So the idea is it looks like people who are immune recover and don't get reinfected. And again, that gives us, I think, a little bit of hope that it does look like there's a good immune response, which gives you hope that potentially a vaccine, a good effective vaccine, can be developed for this. But that's based on the information we know now. It looks like people who recover look like they can't get infected by this exact same strain. Over.
Okay, so Ian, I know you have to go, but is there anything that you'd like to share with us as far as on the prevention side and on the response side?
Yeah, no, well, just go back to some of the stuff I said earlier. I mean, this is sort of a rapidly evolving situation, and it's going to be, I think, complicated and challenging for all of us here in the next, week to potentially month or two. And so I would say, stay in close contact with your state and local health department colleagues. CDC is trying to put up guidance. And I think at the end of the day, we're going to need to work together, come together as communities. And again, I think the biggest emphasis for us is this idea of trying to slow spread in communities and protect the most vulnerable, those that are older and have underlying conditions, because those are the people that are going to be affected the most. So appreciate you guys actually listening to me today. I know that I didn't have as many answers as you wanted, but I think we're learning a lot as we kind of move through this, and hopefully we'll have better answers for you over the coming weeks and coming months. Over.
I'd like to thank you, Ian. I mean, obviously this is a new virus. It's rapidly evolving. We're learning as we go, so we greatly appreciate your sharing the science with us. And along that lines, you know, one of the things we've started with is it's important to exclude ill workers. And, you know, the House has passed a bill that basically would compensate employees if they're excluded. And that's working its way, you know, through the Senate. So I think that that's important because we know that many food workers have two jobs. They can't afford to be out if they're, you know, because economically they can't afford to be out ill. So getting them compensation so there's not an economic incentive to work while ill is very important. So something to consider. We've got the questions. We're going to try and get this webinar up as quickly as possible, and there were a lot of people who couldn't get in. So as soon as we can get it up online, we'll send an email to everybody telling people it's available. Any other comments? I know, Ian, you got to run.
Nope, just thank you guys for listening today, and happy to come back at a future time and tell you when I know more.
All right, thank you very much. And with that, I guess we'll end the webinar. So thank you.